Hello, today's lecture is going to be on theories around health behavior. So what we'll be talking about is looking at different theories in health behavior and issues around those theories. When we talk about theories, we're looking at why do people do things that are bad for their health, such as smoking cigarettes or drinking too much alcohol when they know they're bad for them. Why do people not do things that are health enhancing, like exercise or eat low-fat foods? And why do people not do things that maximize likelihood of better outcomes, such as wearing seat belts or doing preventative stuff, getting vaccinations, getting flu shots, that sort of thing? So why do people smoke cigarettes, drink too much alcohol, overeat, fail to follow their doctor's recommendations? If we had the answers to these questions, we would be able to cut out a lot of our expenses in the healthcare system. One theory is trans-theoretical model, and it looks at the stages of change, and it's really looking at ordered categories along a continuum of motivational readiness to change a problem behavior. And I've given you a website here that you can go to and find out more about this theory. It really looks at kind of the 5 stages of change. It looks at pre-thinking about change. So you have no intention to change behavior in the foreseeable future or the next 6 months. So you're really in the pre-change phase. Then there's you're contemplating whether you're going to change or not. So you intend to change within 6 months. You're open to feedback and information about how to change, but you're a little bit ambivalent about the cost and benefits of their behavior. I was, talking to a friend who's been a smoker forever, and she was talking about the e-cigarettes, and she was talking about it and would she gain weight if she stopped. So she's thinking about it and she's intending to do it, but she really hasn't taken any action yet. Preparing is where you're actively planning change and already taken some steps towards action, such as reducing frequency of problem behavior. So someone in that stage may already be thinking about cutting back on cigarettes. Like they're thinking they're going to stop, so they're going to start cutting back to make it easier. Action is modifying behaviors, experiments, or environment in order to overcome their problems. It involves overt behavioral changes and requires commitment of time and energy. And then the maintenance is really the last phase, and that's sustaining change and resisting temptation to relapse. And this model was generally taken from the addiction area. So addiction behaviors is where this theory is sort of lends itself, and you'll find the most of the literature on that. The other is a health belief model is a different theory. And I'm just going to, really my goal here is just to introduce you to lots of different theories. I'm not going to advocate for one theory over another. I'm simply going to give you some information and let you research more about these theories. The other is the health belief model, and really it's looking at susceptibility, severity, cost, benefit, cues and motivation, and barriers. If we look at susceptibility, it's how likely one thinks a bad outcome, for example, getting sick or a disease, is if the behavior persists. How likely are you to get lung cancer if you don't stop smoking? Severity, how severe are the consequences? If the consequences are mild as opposed to severe, the more severe the consequences, the more likely someone is to change. If the consequences are not very severe, then someone's not very likely to change. And then the alternative behavior will reduce the likelihood of the negative consequences, and if the benefits are perceived to outweigh the cost. So what are the pros and cons of all of this? And then what are the cues, internal or external, that help convert intentions into behaviors? And so this is what we're looking at. And so barriers are if there are not significant psychological, financial, or other costs or barriers to engaging in the behavior. So it's really looking then at what's the brick wall in front of people that's keeping them from changing. So here's sort of it laid out in an example. Jane is not likely to continue smoking because she thinks that she might get lung cancer if she continues to smoke. She believes that dying from lung cancer is a terrible way to die comparing to other ways to die. Jane does not find smoking to be pleasurable. It leaves her with bad breath, and it actually is a financial burden to her. And her friends are supportive of her quitting. So there's an absence of barriers. So this would be it. John is likely to continue smoking because he agrees with the tobacco industry that smoking doesn't necessarily cause lung cancer. You can get lung cancer any old way. He believes that dying from lung cancer is not any worse than any other way of dying. You got to die some way. You might as well die of lung cancer. John feels that smoking relaxes him and being stressed is worse than the other consequences. And his friends offer him cigarettes all the time, and everyone he hangs out with smokes. So there are a lot of barriers to quitting. And so this is what this model is looking at: the susceptibility, the severity, the cost, and the benefits, and the barriers. Another theory that we're going to look at, or that I'm going to mention, is the theory of reasoned action, and it's very similar. It looks at intentions, attitudes, and subjective norms. And under attitudes, we're talking about beliefs and values. And then under subjective norms, we're talking about beliefs about what others think you should do and motivation to comply. And so these are all, they're looking at the same issue, just a little bit of a different slant on it. So someone is likely to drink and drive if, for example, the attitude, Bob feels more at ease when he drinks. And the subjective norm, Bob feels that his colleagues encourage him to drink after work and he wants them to like them. And the intention, Bob intends or expects to drink with his colleagues after work and then drive home one or more times in the next 30 days. And so that's what we're looking at. So if you're going to intervene, you have to then intervene with the attitudes, subjective norm, and the intentions. And so a lot of this then lends itself to a lot of the cognitive behavioral stuff, motivational interviewing. And so once we understand this type of stuff, whether it's whatever theory you're looking at, once you realize what are the factors, according to the theory, that are causing someone to maintain or continue the negative behavior, then we figure out how best to change it. And oftentimes that's with something like CBT or motivational interviewing or something like that, or an environmental intervention. The other thing we'll look at is spirituality and health. And because that kind of goes along with looking at how theories relate to health. And if we look at spirituality, we're looking at the conceptual themes of spirituality. And we're looking at how someone attaches meaning and experiences in health. And often that's through their spirituality. And I just want to kind of clarify these two concepts. Religion means to bind together and believe in a reverence for a supernatural power, regards as a creator or governor of the universe. Whereas spirituality, on the other hand, is defined as dynamic, personal, and experiential process of belief. And so we need to be sure that we're clear about these two concepts. And if we look at the trend is moving towards spirituality research. And spirituality is really defined as a subjective experience. There's a distinction between spirituality and religion. They're very different concepts and have different meanings and different kind of experiences around them. Spirituality has implications for health-related outcomes. And previous emphasis was on external indicators, whereas current emphasis is more on subjective indicators. When we look at spirituality and quality of life, there's a lot of overlap of these concepts. And most of the current kind of research around quality of life looks at it in a multidimensional framework, where they look at it as physical, social, psychological, and spiritual. And if we look at what is it that social workers do, social workers really function in the domain, in 3 out of these 4 domains. And oftentimes, the treatment team, being the nurses and physicians, really focus simply on the physical concept. But there are other 4 domains, and they're social, psychological, and spiritual. And it's the social worker and the allied health professionals that really deal with these other 3 domains. And, when we look at quality of life, they're often rated as equal dimensions, that people value these in the same way, yet most of the emphasis is simply on the physical. Here's sort of another proposed framework of spirituality and the quality of life, and is looking at how these domains do, and it comes down to the life satisfaction, perceived quality of life, and subjective well-being, and then on to dimensions of life. I actually prefer this kind of framework, and is what, when in my research, generally what I use is this multidimensional framework. I do a lot of quality of life with cancer patients and other health issues, looked at HIV and AIDS and stuff. And I really like this. This is very simple, and really looking at these 4 domains and how they play out: the physical, the social, the psychological, and the spiritual. And then getting back to sort of implementing research, really when looking at what affects these 4 domains, and then how do we intervene as health and hospital social workers to make a difference within the social, the psychological, and the spiritual. Not so much the physical, unless it's helping people relate. You know, a lot of times it's we can do things like techniques to decrease pain. You know, as like the psychological relates to the physical pain, and so a lot of those kind of interventions. And again, it's a lot of this is where the psychologist, the social worker, and the religious person will all come together to sort of improve quality of life. Anyway, I just wanted to give you a brief overview of the theories, kind of the prominent theories within health behavior, and really introducing you to the concept of spirituality and quality of life. Thank you very much.